Perfect. So thank you for the invitation. It's a pleasure for me to be here to discuss the role of chemoradiotherapy in the neoadjuvant treatment in pancreatic cancer. So for those of you that doesn't know me, I am Teresa Macarulla. I'm GI medical oncologist and I work in Vall in Barcelona. So first of all, what are we talking about? Really, borderline resectable disease is around 10% of pancreatic cancer patients, and resectable pancreatic cancer patients is around 20%. I think in the last years, in the last decade, we see that these percentages are changing, and probably we have less resectable pancreatic cancer patients, and we have more borderline resectable disease because the definitions are something that is changing. We will see in the next slides. So we will see that in this case here in this slide, what we can see is how we define that the patient with a pancreatic cancer and localized disease can be unresectable, can be resectable, and this is black or white, but then there's different definitions that is a gray in which we can define that the patient is borderline resectable, and it depends of the definition that is changing during the time, and also it depends of the experience of the center, the surgeons, and the experience of the oncologist. So that's something that is not black and white. Then one of the definitions that is more followed and more common is the NCCN definition of localized pancreatic cancer. And here you can see that they define the borderline resectable disease as a tumor with some relation with the vessels that are around the tumor. For example, they define a borderline disease when there is a contact with the mesenteric artery less than 180 degrees, or for example, when the contact with the venous mesenteric superior venous are more than 180 degrees or less than 180 degrees, but with a irregularity in the vessel. So that's very well defined in the NCCN definition, but here there's only the anatomical relation between the tumor and the surrounding vessels. However, we know that we have new definitions that are published in 2018 in this case, in which we take into consideration not only the relation between the tumor and the vessels surrounding, so it's not only an anatomical definition, but we take also into consideration the biological definition, and that means that we take into consideration the level of CA99. In this case, in this definition, they said that a patient with a CA99 level more than 500, a diagnosis with a normal bilirubin, it has to be considered a borderline disease, not resectable at front, and also the implication of regional lymph node. And also important, the relation between the tumor and the condition of the patient. So sometimes the patient presented a depressed performance status, an ECOG performance status 2 or more, and related with the tumor, sometimes with the tumor border. And this has to be considered into consideration when we define a patient with a borderline disease. So it's difficult to consider a patient with a tumor with a resectable disease, but with ECOG performance status 2. This patient is very difficult that can go directly to surgery. So for this, it's crucial, it's a must to have a multidisciplinary team. In this multidisciplinary team, it's very important to discuss these patients with a localized pancreatic cancer, especially at diagnosis. It's important to have an oncologist with an expertise in pancreas, also a nutritionist. Especially it's important a nutritionist when especially it's important a nutritionist when we need to do neoadjuvant treatment in a patient, because we can improve during this neoadjuvant period the nutritional status of the patient, and of course it will impact in the complication of the surgery, the mortality and the morbidity of our patients. So it's crucial to have this team involved since the beginning. Also, the pathologies will be important, especially once the patient is go to the surgery, and then when we have the tumor resected, and then to do a proper analysis of this tissue. It's really crucial to have a pathologist who is really an expert in pancreatic cancer, because it's not easy to do a correct pathological analysis. Then the radiologist, it's crucial, especially at the beginning of the diagnosis of the tumor, in which the radiologist will define if the CT scan or the MRI that we have with the diagnosis presented the enough quality, if we have the phases that we need, the arterial phase, the venous phase, in order to define the relation between the tumor and the vessels surrounding. And also these radiologists will define which is the relation between the tumor and the vessels. And finally, of course, we need the surgeons, we need an expert surgeons who know this kind of surgery, who are trained in vessel resection. And that's crucial. So really when we have a localized, we have to go back. When we have a localized pancreatic cancer tumor, I think it's crucial to have a multidisciplinary tumor board in a high volume center. Why? Because it's only in a high volume center where we can find all these specialists and these specialists focus and train in pancreatic cancer. And where we know that once we have defined that the patient presented a locally borderline resectable disease, so this tumor that probably presented a low probabilities to have an R0 resection rate, it go directly to surgery. So this is a patient that we know that need a neoadjuvant strategy. We will see in this presentation which is the best neoadjuvant strategy and which is the data that we have with radiotherapy. This is one of the first meta-analyses that was published, and that analyzes the role of neoadjuvant treatment. In this case, these meta-analyses include different neoadjuvant strategies, only chemoradiotherapy or chemotherapy plus chemoradiotherapy, and include patients with locally advanced disease and with borderline disease. So it's a mix of patients and with a mix of treatments. But the question is that they analyze this neoadjuvant strategy compared with upfront surgery regarding the pathological report in the surgery. And we see, and it's consistently in all the pathological issues, it's consistently reported that when we have patients treated with a neoadjuvant strategy compared with upfront surgery, we have a less PT3, PT4, so more PT1, PT2. We have less lymph node involvement, and also we have a higher R0 resection rate. We have less perineural invasion and less lymph node invasion. So we have a more favorable anatomical characteristics in those patients that go with that are treated with neoadjuvant strategy. But we have some pros and we have some cons from the neoadjuvant strategy, and this is the discussion that Naureen Starling did this last ASCO meeting. And they review all these pros. First of all, it's obvious that if we start with neoadjuvant treatment in these patients with a borderline disease, we start treating the metastatic disease earlier. We start, of course, we improve the administration of chemotherapy because in general, the performance status of patients are better if you start chemotherapy before surgery than if you start after a pancreatectomy. Also, you improve the R0 resection rate, and this can have an impact in overall survival. We select those patients that progress during a neoadjuvant treatment as those patients that can present an unfavorable biology, and are those patients that never have to go to surgery. And finally, we have in vivo demonstration of the chemosensitivity. But we have some problems with the neoadjuvant strategy. First of all, that we have some patients that progress during a neoadjuvant strategy, and we lost the opportunity to go to surgery. Also, that we have, of course, some toxicities related with chemotherapy or chemoradiotherapy that can limit the surgery or can affect the surgery. And also that we need tissue, we need a diagnosis, and sometimes it could be difficult to have enough tissue to do the diagnosis, and sometimes you have to repeat the biopsy, and it means time, and it's time that sometimes put us very nervous and the patient more. And of course, the other problem is that sometimes patients with a tumor in the head of the pancreas need an adequate biliary stent in order to treat the increase of bilirubin that presented some of these patients. And of course, again, this means time and sometimes some complications associated with this stent. So, which evidence we have that the neoadjuvant chemoradiotherapy can have an impact in the overall survival of our patients? Well, the first randomized trial that was presented and published was this Korean trial, in which they pretend to include 110 borderline resectable pancreatic cancer patients, and in fact they plan 150, but finally they include only 57 patients because in the interim analysis show that the neoadjuvant strategy was better in overall survival than the adjuvant strategy, and for this reason they stopped the recruitment. So the number of patients treated in this trial is a small number of patients. The trial randomized the patients with borderline disease to be treated with chemoradiotherapy. The radiotherapy was conventional radiotherapy with 45 grays, and concomitant with radiotherapy they give gemcitabine 400 milligrams per square meter, and also then the patient go to surgery, and after surgery patients were treated with gemcitabine at a standard dose for 4 cycles. The other group of patients were randomized to be treated with upfront surgery and then chemoradiotherapy with the same schedule and gemcitabine for 4 cycles. And then the primary endpoint of the trial was 2 years overall survival. It's important to note this, that only 27 patients were allocated to the neoadjuvant strategy and 23 patients were allocated to the upfront surgery. So the number of patients are only limited. So then here we have the results. The trial is positive in the neoadjuvant strategy because the 2 years overall survival was higher in the neoadjuvant strategy group for 40.7% compared with 26.1% with a hazard ratio of 0.4. So really, this means that it was the survival was superior in those patients treated with the neoadjuvant strategy. Also, the median overall survival was higher, nearly the double in the patients treated with the neoadjuvant strategy, 21 months compared with 12 months in the adjuvant strategy. And our zero resection rates, again, it was superior in the neoadjuvant strategy, 51% compared with 26% in the patients that went to upfront surgery and then received the adjuvant treatment. The overall recurrence was more or less the same between both arms, really high in both arms. Unfortunately, nearly 90% of patients progressed, and the local regional recurrence were a little bit higher in the neoadjuvant strategy, 35% compared with 27% in the patients that go to upfront surgery. So this is the first randomized trial demonstrated that the oncological benefits of the neoadjuvant strategy in this borderline population. It's only a small number of patients, a small sample size, but the message is clear. So we have another clinical trial that was presented in ASCO 2020. That is a British, the trial from the UK group, the SPAC5F trial, in which they include patients, around 90 patients with borderline resectable pancreatic cancer tumor that were randomized to be treated in different strategies. The first arm of the trial is to go up to directly to surgery. The second one is to treat the patients with gemcitabine and capecitabine as a neoadjuvant strategy for 2 cycles. The other arm is to treat the patients with FOLFIRINOX as a neoadjuvant strategy for 4 cycles. And the last arm is to treat the patients with chemoradiotherapy with 50 grays of radiotherapy and a concomitant with capecitabine. And then all patients go to surgery, and all the patients receive adjuvant chemotherapy after surgery. So the primary endpoint of the trial is the recruitment rate and the resection rate, R0 and R1 resection rate. And we have secondary endpoints like overall survival and toxicity. Well, as you can see here, again, the number of patients included in each arm is only a small sample size. And if we see the patients included in the chemoradiotherapy arm, it was only 16 patients. So here you can see how they define the borderline resectable disease, and they define it as a patient that lost of normal tissue plane between tumor and vessels, or venous involvement of the mesenteric venous, superior mesenteric venous, or the portal venous, or the confluence between both, or tumor abutment less than 180 degrees of the arterial mesenteric, superior mesenteric artery or celiac axis, and no evidence of distant metastasis. And they decided you have to have the A or and or B or C and D. So you have to combine some of these points to consider a patient as a borderline resectable disease. Respect the chemoradiotherapy arm, they reported that 38% of the patients, of these 16 patients, received all planned chemoradiotherapy, and that's important. So if you see the percentage of protocol radiotherapy dose, it was 100%, and the percentage of protocol capecitabine dose was 84%. And you can see here that the resection rate was they analyzed together, so they reported the result analyzing together the patients that go up from surgery or the patients that receive neoadjuvant treatment. And they put together all the three arms. And with this, they reported the resection rate of 62% compared with 55% in patients with neoadjuvant strategy, with no statistically significant differences between both arms. Here we have the resection, the R0 resection rate that was 15% in those patients that go directly to surgery, and was 23% in those patients that receive neoadjuvant strategy, whatever it was this neoadjuvant strategy. And the differences again was not significant. But then they reported that the 1 year, the 12-month survival rates, and you can see here it was superior in the neoadjuvant strategy altogether, 77% compared with 42% in patients that go directly to surgery. And also when they put the different arms in a different numbers, but the numbers are really small, but the chemoradiotherapy arm reported a 1 year overall survival rate of 64%, compared with FOLFIRINOX that reported 84% of 2 years overall survival, and in JEPCAP 79%. So they conclude that there was no difference in resection rate between the arms, between neoadjuvant strategy and directly to surgery. However, the neoadjuvant strategy, whatever it was, this neoadjuvant strategy, had a significant overall survival benefit compared with go to directly to surgery. So again, another clinical trial with a small sample size, but that benefit the strategy of neoadjuvant strategy in patients with borderline disease. Here we have the first randomized phase 3 trial that evaluate the neoadjuvant strategy in this group of patients. This is the Präoperative trial. The Präoperative trial include half of the patients were borderline resectable tumors, but half of the patients were resectable disease tumors. And the primary objective of this trial, it was overall survival. Patients were randomized to be treated with patients were randomized to be treated with surgery up front and then 6 months of adjuvant gemcitabine, or patients were randomized to be treated with chemoradiotherapy with gemcitabine, surgery, and then chemotherapy for 4 months with gemcitabine. And you can see here the doses of gemcitabine, that was the standard dose, and the radiotherapy that it was 36 grays in 15 fractions. Here you can see the results of the trial. First of all, you can see that there was differences, statistically significant differences in R0 resection rates and N0, the N0 resection, so that the lymph node invasion in both groups. You can see here that 72% of patients that went to neoadjuvant strategy were R0 resection rates, compared with 43% in patients that went to upfront surgery. The difference is statistically significant. And then also the N0 resection was higher in those patients that go to neoadjuvant strategy, 65% compared with 18% in those patients that go directly to surgery. The primary endpoint was overall survival. In the first report of the median overall survival, there was no differences between both arms. However, this year in the ASCO meeting, They presented the updated overall survival, the 5-year overall survival data, and you can see here that there was an important differences between both arms, being 20.5% in patients with neoadjuvant strategy and only 6.5% in patients without prompt surgery. So really, with a long-term follow-up, the patients benefit more if they were treated with this neoadjuvant strategy. Also, if we analyze only patients that can go to resection, okay, so some of the patients with a neoadjuvant strategy never can be resected, but if we analyze only patients that can be resected, the differences are higher, and you can see here that those patients presented a 5 years overall survival of 33.9% of overall survival in the neoadjuvant strategy, compared with 8% in the patients that go to upfront surgery. And also, if we select only those patients that can go to adjuvant strategy, patients that can start adjuvant strategy, which is a selection, of course, but in this case, you can see here that again, the difference is higher than the global population, benefiting again the neoadjuvant strategy. And also, they did a subgroup analysis in which they analyzed separately patients with resectable disease, that are half of the patients, compared with patients with borderline disease. And it seems that those patients with borderline disease presented a more or a greater benefit from the neoadjuvant strategy, with a hazard ratio of 0.6, compared with patients with resectable disease, with a hazard ratio that was 0.9. And the same with R0 resection rates. This is a predefined subgroup analysis, but we have to take into consideration with caution, because the interaction test of hazard ratio between both groups was not significant. But it seems there's a trend here. So, which is the message from this Präoperative trial? This is the first trial to assess the neoadjuvant strategy in localized pancreatic cancer. This is something that we have to take into consideration. However, it is not clear that the neoadjuvant strategy using this trial, that is gemcitabine-based chemotherapy, is a new standard, because it seems that maybe we have new strategies that can be better, or new chemotherapies regimens that can be better. And finally, we don't know which is the contribution of radiotherapy in this strategy, because we do not have an arm with only chemotherapy in the neoadjuvant strategy, and we don't know if this chemoradiotherapy is necessary or if it's optimal. We have the last trial that I want to discuss with you is the Allianz 12-15-01 trial. This is a randomized phase 2 trial that includes patients with borderline disease, only borderline, and these patients were randomized to be treated with FOLFIRINOX for 8 cycles, and then surgery, and then FOLFOX for 4 cycles. And then in the experimental arm, they include here, after 7 cycles of FOLFIRINOX and prior to surgery, they include this radiotherapy. This kind of radiotherapy is a local radiotherapy, SBRT, in the majority of patients. So this is the radiotherapy that they use, and the patients go to surgery, and then FOLFOX for 4 cycles. And the primary endpoint of the trial was 18 months of overall survival. Here you can see the results, and as you can see here, the best result in 18-month overall survival was that the patients treated only with FOLFIRINOX without radiotherapy, with 66.4% of 18-month overall survival, compared with 47 in those patients that include radiotherapy in the neoadjuvant strategy. We can see here the resection rate was higher in the chemotherapy-only strategy, with 49%, compared with 35% in patients treated with radiotherapy. You can see here that patients treated with radiotherapy as a neoadjuvant strategy presented higher incidence of grade 3 and 4 adverse events. So they conclude, the authors, that the arm with radiotherapy did not meet the requirements to conclude efficacy. Nowadays, we have some clinical trials that are ongoing, and we are recruiting, and we are waiting the results. In this case, a very interesting trial that is a Präoperative trial that includes patients with borderline resectable disease, and also borderline and also resectable disease. And these patients are randomized to be treated with FOLFIRINOX for 8 cycles and then surgery, or are randomized to be treated with chemoradiotherapy with gemcitabine, surgery, and gemcitabine for 4 cycles. In this case, we will answer the question if it's better to give a good chemotherapy schedule like this, FOLFIRINOX, or it's better to give a chemoradiotherapy with gemcitabine. So this is ongoing and we have to wait the results. The primary endpoint is overall survival. And then we have two interesting phase 2 trials that are again ongoing that evaluate the role of radiotherapy as a neoadjuvant strategy. The first is a PRODIGE 44, is the French trial that include 90, it is planned to include 90 patients with borderline disease. Patients are randomized to be treated in the standard arm with neoadjuvant FOLFIRINOX strategy or neoadjuvant FOLFIRINOX, chemoradiotherapy with capecitabine, concomitant with radiotherapy with 50.4 grays of radiotherapy, then surgery, then adjuvant gemcitabine or 5FU. And the primary endpoint of the trial is RZER section rate. And then we have another trial that is a British trial, a Primus 002. It's a trial that, again, a randomized phase 2 trial that includes patients with resectable disease or borderline disease, that patients are randomized to be treated with FOLFOX and nab-paclitaxel, chemoradiotherapy with capecitabine, and then surgery, or gemcitabine and nab-paclitaxel, chemoradiotherapy with capecitabine, and then surgery. The primary endpoint is time to progression, and there's an important biomarker analysis in this trial that it will be really interesting to know. But nowadays, these trials are ongoing, and we have to wait the results. So take-home message for which is the value of preoperative chemoradiotherapy in the neoadjuvant strategy in pancreatic cancer, borderline pancreatic cancer. Well, first of all, the definition of borderline resectable disease is something that is dynamic, that is changing during this last decade, and it depends on the experience of the different hospitals, different surgeons. The multidisciplinary team is a must in these localized pancreatic cancer patients in order to define and to put the patient in the correct definition and to plan the strategy altogether. The SPIKE-5 trial is demonstrated that the neoadjuvant strategy improves overall survival with different strategies. The Präoperative trial is the first randomized phase 3 trial that demonstrated with a long follow-up that the neoadjuvant chemoradiotherapy impact in overall survival compared with adjuvant strategy. The Allianz trial, however, failed to demonstrate the benefit of radiotherapy, in this case is SBRT technique, as an adjuvant strategy. And of course, I think the trials that are ongoing will help us to elucidate the best neoadjuvant strategy, the best neoadjuvant chemotherapy strategy, and if the radiotherapy has a role in this neoadjuvant strategy, and which is the best neoadjuvant radiotherapy technique that we have to use. It's different to use conventional radiotherapy with concomitant with capecitabine or with gemcitabine, or to use an SBRT or one of these new techniques that of course also have to be evaluated in clinical trial, the role of these new techniques. So with this, I think it's all from my side. Thank you for your attention. I'm happy to open the discussion and to evaluate your question. Thank you.
Teresa, very good overview, excellent. So we know where the data is, and it is a little bit unsecure now what to do. So there was this Präoperative which was in favor of the radiochemotherapy, and now the Allianz trial came in, and the pendulum went a little bit back to not use radiotherapy. How often are you using radiotherapy as in a pre-adjuvant setting? Are you now rather for it or against it?
Yeah, I am a little bit against it. So not against it, but so I try to use the borderline disease. I try to use chemotherapy, a good chemotherapy, ideally for me, FOLFIRINOX in young patients and fit patients. And patients that are not so fit or not so young, maybe patients more than 70, I use gemcitabine and nab-paclitaxel because the SWOG 15 trial demonstrated that there was no differences between two regimens. So they use FOLFIRINOX or GemNab as a peri-operative strategy, and both the overall survival was similar between both. So I feel comfortable using GemNab or FOLFIRINOX, but in fit and young patients are 10 Then, so if the patient after 4 of chemotherapy are considered resectable, technically resectable, I try to go directly to surgery. But I think it's important to know that, I don't know if you have to be clear which is the best therapy we can use. Because of course, for me, if you stop after 4 months of FOLFIRINOX, and you start with a conventional radiotherapy concomitant with capecitabine, you are, for me, under-treating the patient, no, for a lot of time, because maybe you have to treat with a conventional radiotherapy, you have to treat the patient during 5 or 6 weeks, and then you have to wait 6 weeks more before surgery. So you stop the chemotherapy for a long period of time. So I am not convinced with this strategy. The SBRT, the question is, for me, it's good because it's short and you can go directly to surgery. But of course, the Allianz trial is disappointing in this strategy. So I am not convinced to use this in this group of patients.
Okay.
You are using
question.
In Germany, you are using radiotherapy strategy.
Yeah, we do sometimes. We had just today saw a patient where we tried to make her operable. She was more or less borderline resectable, or better locally advanced, depending on the definition, and she was not able to be operated finally. She did not really work. Yeah, we do try to use it. We do try, but the data is a little bit difficult. You know, the PREOPANC is for me to rock in the best trial to orientate, and then it is the long radiotherapy, as you said. It's not the short one, and also the radiation oncologist here is nodding that we are doing the long radiotherapy. They are not convinced it's the short one. Is that correct, Christina? Yeah. So
I think in pancreas setting, stereotactic radiotherapy is not a good strategy because the analogy to surgery. Good cases of stereotactic radiotherapy are the good cases we can operate. And that's huge volume we can do a stereotactic radiotherapy, a good stereotactic radiotherapy. And in the Allianz trial, I have just checked and I learned yet. Thank you very much for the presentation. But the dose was used 5 times 5 Gray. That's really in equivalent doses, something about 40 Gray. That's too less for a correct neoadjuvant treatment. And then you operate the patient, but you don't give the time to downstage. It's true. On one side, when you give stereotactic therapy, you have a short neoadjuvant time. It's interesting because you don't use time for surgery. But on the other side, first you have a selection for the patient, where responds or where does not respond. Second, you don't allow time to run the surgery to work.
Yeah.
So of course you don't have an answer.
Yeah. Yeah, correct.
And if treat volume or not operable, they are not candidates for the therapy for vaccinated. Something different is the palliative setting, you want prolonged survival, you have patients with symptoms, but the goal is to take people to operation if we do a präoperative treatment, it's conventional.
Okay. Yeah, so she also, is strongly in favor for conventional radiotherapy because the volume and the kind of radiotherapy is not the one applied to someone who wants to cure or want to operate. We had Matthew Katz he was connecting during the ASCO GI. We had a meeting here in Zurich. And he was actually in the operations theater and connecting to us. And he had his trial and he presented that trial and he also presented it now. And he then said, at the cancer center where he works, in the Anderson Cancer Center, that they do treat all patients, the operable one, 80 to 90% of the operable patients, they treat now these days with neoadjuvant chemotherapy. And I was amazed to hear that I know the pendulum is swinging to that you treat everybody with neoadjuvant chemotherapy, also the operable ones. But what do you think about that? I mean, he said 80 to 90% of those patients at T2 and 0 operable, really clearly operable. You're not going to operation theater, they do neoadjuvant FOLFIRINOX, and then they operate. I couldn't ask him really the protocol how they do it, because do you do 6 months of FOLFIRINOX before you operate, or how are they doing it? They do CT scans every 2 months, and then when they respond, they go ahead. But I don't know when they operate. I couldn't ask that. But are you doing this as well in the clearly operable patients? Are you doing chemotherapy up front and then operate second?
I would like, so I am in favor. So I think to start with chemotherapy, it's not a bad treatment for the patient. I am completely sure. But of course, we don't have data or not enough data probably in patients completely resectable, but completely is completely, with a negative tumor marker, with a small tumor, with no relation with the vessels, young. It's very difficult to explain to the surgeons. You have to start with FOLFIRINOX for 6 cycles. No? It's very difficult, but we try. So we try to do it, and we try to treat the patients with neoadjuvant strategy as much as we can, because we see that then at the end, you have to give chemotherapy at all your patients, ideally, So you give adjuvant and FOLFIRINOX at all your patients, if you can, But the majority of them we treat with adjuvant strategy. So at the end, you will give chemotherapy before or after the surgery, or this is the ideal situation, and always is better before, because you increase our zero resection rate, you decrease the pathological characteristics of the tumor. So I think it seems clear that in the resectable disease, you have to go also to the neoadjuvant strategy. But of course, you don't have a clinical trial, a phase 3 clinical trial that gives you data to do it and to say it in all the places. But we try, we see all the tumor markers, and if the tumor marker is increased, this is an excuse to start with chemotherapy. We see the performance status of the patient, all the relation with the vessels. We try to treat as much as we can, and we are really treating a lot of patients with the neoadjuvant strategy. I think it's a good strategy. And also I am convinced every day more and more that you have to give as much as you can before the surgery, because then after surgery sometimes, especially if there's a vessel resection and some complicated surgery, it's more difficult to give FOLFIRINOX. So if the patient is tolerating well, we try to give between 4 and 6 months before surgery, and then go to surgery, and that's all, and stop there.
Okay, that's also a clear statement. So that you, if you are not in a trial treating a patient, then you also would try to give the neoadjuvant chemotherapy also for operable ones. How do you check then? Do you also do CT scans every 2 months to see how they evolve?
Yeah,
okay.
we did, yes. We perform a CT scan every 2 months with the tumor marker, but the first CT scan is only to be sure that it's not progressing. But the important one is the second CT scan at 4 months, and also the one at 6 months. We share the images with our surgeons, and we decide if we go to surgery after 4 or after 6 months.
Okay, good. So you do every 2 months a CT scan, and then you decide at each time point if you go for surgery or not. I think that's probably good. And if you have not completed the chemotherapy the 6 months, you would probably try to add some adjuvant chemotherapy if that's still possible. Yeah.
At the end, we try that the patient receives 6 months of chemotherapy. So if the patient is treated only with 4 months before surgery, we completed it with 2 months more after surgery. But our experience is that sometimes it's difficult, especially with FOLFIRINOX, because sometimes there's a lot of diarrhea and some side effects of the surgery. Especially with this borderline disease, that you have to do an extensive surgery with some vessel resection, and sometimes there's a lot of side effects. So complicated to complete the FOLFIRINOX.
Okay. Yeah, that's true. So yeah, that's fully true. Thank you very much. I think that's a really valuable insight also from how you see the data, and also for us, it's inspirational to also try to go more for neoadjuvant therapy. If outside the trial, if we can put them into trials. Thank you very much. Other questions from the attendees? No more questions. So thank you very much, Teresa. A very warm goodbye to Barcelona. Hope to see you again soon. And a very nice evening.
Thank you. Thank you.
Bye-bye. Thank you.
Bye. Bye.